Good. Well, thank you very, very much for inviting me to speak. It really is a pleasure. My two most favourite things are classical music and chocolate. So you can imagine how much I would love to be in Vienna now, but actually virtual Vienna is almost as good. And I'll eat a bit of chocolate after this talk. So as Pippa said, my name is Anna Spathis, and my clinical and academic background is in the management of symptoms, particularly breathlessness and fatigue. And in this short talk, I'm just going to speak for 15 minutes on the topic of improving well-being by relieving symptoms. And I'm going to use breathlessness as the main example of this and introduce you to the breathing, thinking, functioning model, which you can see represented in that little picture, as a way to facilitate, to make easier symptom management. So I'm going to now try and change slides. So my starting point is to talk about what I think is quite a fundamental difference in perspective between healthcare professionals, perhaps like myself, and people living with lung diseases and their caregivers. So traditionally, health professionals, particularly doctors, think of treating patients with diseases, but that leads to efforts continually to improve the disease, but people may still have symptoms, and then it can become hard because the health professional knows that they're doing all they can to treat the underlying condition. And this leads to a sort of helplessness, and health professionals often don't focus on the symptom because they're not sure what they can do. Whereas people with lung diseases, well, they're people, not patients, and they're not diseases. What they're experiencing is not the disease, they're experiencing symptoms, as so many people listening will know. And symptoms can be physical, like breathlessness, or psychological. And I've given a few quotes there, but just want to highlight the sense of helplessness and the invisibility of living with symptoms which don't show on the outside, but certainly are experienced on the inside. And I just want to highlight the place for caregivers here. And Francesco, who's doing the second part of this session, will be talking more about that. But it's so difficult for caregivers of people with lung disease as well. So we're just going to going to push ourselves technically. Budge, would you mind launching a poll which asks the question of you all, have a guess, what do you think are the most common symptoms experienced by people with lung conditions? And you're allowed to select a couple. So I'll just be quiet for 20, 30 seconds while you select the ones that you think are most common. Okay, Budge, would you mind sharing the poll results? Ah, that's very interesting. So I'm hoping you can all see that, but it's reflected really well the reality. And fatigue and breathlessness are indeed the commonest symptoms experienced by people with chronic lung disease, with anxiety closely behind. And between 50 and 90% of people with significant lung disease experience these symptoms. Depression would be the next highest, exactly as you've put, but I want to make the fundamental point that all the symptoms listed here are experienced by at least a quarter of people with chronic lung conditions. So symptoms are common, and Budge, thank you. If we could remove the poll, or maybe I can do that, thank you. The other point I want to make is that symptoms are experienced by everyone, irrespective of the lung disease. So I know so many different diseases are represented here with your patient organizations, but symptoms are transdiagnostic, so cutting across all different diseases. So I'm going to talk about this fundamental difference by saying that let's try moving away from a disease-focused support to symptom-focused support to try to improve well-being. But the reason we need to do this is because symptoms are what matter to people, but the challenge is that focusing on disease doesn't actually improve symptoms that well. And this is the first of the three challenges in a symptom-focused approach that I want to highlight to you. Disease severity has very little relationship to symptom severity. And so if you think of people you know, perhaps with COPD, and how some people may have very mild disease, but really very disabling symptoms, debilitating symptoms, where somebody else may have really advanced disease and yet be managing, still walking around. And so it's this dissociation between the disease severity and the symptom severity is really important to understand. Disease management, I must make very clear, is of course optimizing disease management is a key starting point, but it's often not enough to improve well-being and improve symptoms. The second challenge is that some drugs which are used actually for the symptoms, I'm not talking about drug treatments for the underlying disease. So I'm thinking of things like morphine, which, as Otto said, Freud uh, did suffer from taking it. But morphine, which is often used, for example, for breathlessness, actually the evidence base isn't there. And a definitive study came out in January confirming that drugs like morphine are not helpful for breathlessness. Drugs like benzodiazepines, like diazepam, are often cause more harm than good for anxiety. So drugs are not the way ahead. And that leaves us with non-drug interventions, which are great. And I haven't got time to go through the evidence base. These are quite effective. But there are problems here. People don't really understand them. Why do they work? So they don't engage with them. There are many, many approaches. Just for breathlessness, I could reel these off for ages, but relaxation techniques, breathing techniques, mindfulness, CBT, cognitive behavioral therapy, building up activity. There are so many, but it's hard to know which is the best one to choose. And health professionals often don't have suitable training to help support patients. And a big report was published in England within the last year, confirming that specialist services which are beginning to be set up to manage these challenges are effective, they are helpful, and I've summarized some of the evidence there. But the big problem is lack of access. So people are not getting this type of specialist support. And I work in the Cambridge Breathlessness Intervention Service, which was the first specialist breathlessness service set up in the UK in 2003 and has been emulated in a few places around the world. But there are still only pockets of expertise, mostly within palliative care and respiratory settings. So the key outcome from this report, and what I want to say to you today, is that we need to support people coming from specialist symptom control services to support health professionals in other countries to upskill them with these techniques, and so that they can support their own patients and improve symptom management. So how can we increase access? With training. And this is where the breathing, thinking, functioning model comes in. Now, I won't have time to talk about this in much depth, but just quickly to introduce this to you. This is a health professional educational tool which patients describe that they benefit from as well. And it overcomes many of these challenges that we're talking about, and I'll explain more. So what the model does is it describes vicious cycles, as you can see represented in that diagram, of emotional and behavioral responses to the feeling of a symptom, and I'm talking about breathlessness here as an example, which are quite normal, but unfortunately inadvertently feed back to worsen the symptom. Now, these are normal because any perception of threat in our brains has to lead to emotions and behavioral responses to try to get away from the threat. That's helpful for acute threats, but chronic threats like symptoms, it becomes less helpful. And I'll just go through this quickly. The thinking cycle, I think, will be familiar to many of you, where the thoughts about breathlessness, it's so frightening. It can actually, those feelings of fear, feed back and can change the way, with the hard wiring of the brain, is how I describe it to people, to patients. They worsen the breathlessness, and that can lead to a vicious cycle that goes round and round, and for some people even lead to panic. The functioning cycle may well also be familiar to you. If one's breathless, it's very unpleasant, so you can't be as active so easily. But if you're less active, you become less fit. And as one becomes less fit, the breathing can feel worse. And that again can lead to a vicious cycle that spirals. And finally, the strange thing is when we think about our breathing, the breathing can become less efficient. So people have a tendency to think, oh, I need more air. So taking big breaths in the upper chest, panting with small volume breaths. And that leads to an inefficient breathing pattern that makes the breathlessness feel worse. So how does this model, the breathing, thinking, functioning model, help us overcome those challenges to symptom-focused support and help us support our people who are living with lung conditions? So first of all, it can help make sense of breathlessness. Do you see now why breathlessness severity and disease severity are not closely related? That is because these vicious cycles take over and can make the symptom take on a life of its own that's separate from the underlying disease. We can also see why breathlessness continues and can worsen even when the trigger might have settled. Now, this brings me on to briefly mention COVID, because COVID can be a trigger, as we all know, to significant breathlessness. But some people are getting this so-called long COVID, where even once the infection has settled, they continue with breathlessness. And that might be, for some people, it may be because of ongoing lung damage, but for some people, it may be because of these vicious cycles developing. And in our service in Cambridge, we've treated and are treating many people with these long-term effects of COVID. Although it's early days, it seems to be that this approach is helpful. Now, the other help from this model is that if you can see that there's a vicious cycle which is making things worse, it is motivating because you can see by breaking a cycle, you can improve things. And even better, just small changes that nip a cycle in one place can be sufficient to break the cycle and actually turn it into a cycle of improvement. So therefore, something can be done. That thing when people say there's nothing more we can do here is not true, and small changes can make a big difference. Finally, the challenge of there being so many different psychosocial approaches, and Francesco is going to talk more about this, the model helps us see which is the main vicious cycle for a person and then to focus on that. So it focuses the management. And here's some very brief examples of focused management. We often start by a gentle explanation of the force that is driving the vicious cycle. So for example, I could say to people, it's so natural to feel you need more air in the lungs, but actually it's not the case. There's already plenty of air there. Try focusing on lengthening your out breath so there's more space for the next breath. I haven't got time to go through these, but you can read them and the slides will be available afterwards. And then there are brief techniques which can deal with each of the vicious cycles depending on the main one that a person is suffering from. So here's the recovery breathing technique, cooling the face with a fan or a damp flannel. Many people who may be listening who have experienced breathlessness, I hope that will resonate with you, that cooling is really helpful. Leaning forward and focusing on the out breath, as I was just saying, the 3 Fs, is a wonderful way of breaking the breathing vicious cycle. I've put up here the tranquility visualization that we often share with our patients. Francesco is going to talk about other approaches to break the thinking vicious cycle where anxiety and panic can develop. And then the functioning example, for many of our patients, the thought of exercise is really off-putting, but actually talking about doing your normal activities. So you count the number of steps you make in normal life and then trying to increase that by about 10% each week. And over a couple of months, one's activity is doubled and you can build fitness. So drawing this to an end, we've been teaching using this model for some years now and evaluating it. And here's some feedback that we've received and some of the countries where this is being used. But there is a lot more to do, and we need to do some research with this model, which we are setting up at the moment, trying to work out how we can support community staff to learn about the model and this approach to supporting people with symptoms like breathlessness, and to cascade this type of approach so that many more people can access it. You may have seen in the previous slide that we've received feedback about developing an app. We are duly doing this, and a prototype app is almost ready that we can share remotely with patients in this brave new world where it's so difficult to meet face to face. And the final really important point I want to make is that I've talked about moving beyond single diseases to symptoms which are transdiagnostic, but I want to extend this further and actually say that symptoms come together in clusters. So somebody experiencing breathlessness is very likely to also be experiencing fatigue, anxiety, perhaps insomnia. And this type of approach can be helpful for other symptoms. I've been doing research looking at this type of approach in fatigue. And although it's still early days, the findings are promising. So my final slide now is just to say, of course, management of the underlying disease is really important and a key starting point, but it's not the whole solution. It's not enough when we're thinking about promoting well-being. A symptom-focused approach includes how people are thinking, feeling, and behaving. And by breaking vicious cycles, normal vicious cycles that occur for everyone with these symptoms, it's possible for small changes to make a big difference to improve people's well-being. And I'm now going to hand over to Francesco, who's going to build on this by talking about some of the psychosocial approaches that can be used. Thank you very much.